Dear participant in this important meeting, I wish you a good day. And I thank the Council on Foreign Relations to have invited me to talk to you and you to be there. The subject of today, universal access to care in the context of shortage of health professionals, is a very important one. And Rwanda have faced big challenge in that area because of the genocide of 1994, who have killed so many health professionals and have pushed many others to fall out of the country. Also, infrastructure were destroyed and the country was really upside down. So upside down that many decided that it's a lost cause. And even that there is an article in the Lancet who stated that Rwanda should not be helped. There is no hope there. Hopefully, we proved them wrong and we have achieved the MDGs. I'm very proud that from the community health workers up to the specialists in this country, we have worked hard and make it happen. And we have made it because we have fight for universal health coverage. And I'm going to talk to you about the challenge we had and how we have made it happen. First, after the genocide, we came all together and we identify what is our Vision 2020, where we want to go. And we have designed strategies to reach there. And all those strategies were articulated around fighting poverty and economic development. And the health sector has a big portion of it. So this is the framework where we worked on. But we did that also with a really principle that I'm going to talk about. First of all, there was participation, evidence-based, holistic approach, equity. And also we had the efficiency. So for evidence-based, we have using the science and the knowledge of what happened locally. Because even if we are not a big country, my beautiful country of the Thousand Hills is not a big one, we have difference between regions in the country, and we should not emphasize some actions in the same way across the country. For participation, there is participation of health professionals in the design of the policies, but also in the service for the beneficiary of the service to have a say in the care they receive. And this exists especially at community level, where in each village there is an election of 3 community health workers, one to take care of women and pregnant women and children under 3, 2 others for common disease, and they treat malaria, they treat pneumonia, gastroenteritis, they give advice for nutrition, for HIV prevention and testing, etc. So they really keep, they treat fever, they keep 80% of the burden of disease at village level. So for the participation in that case, it's the village electing them. They just have to know how to read and to write, use a phone, because all the reporting system is based on phone, and they also call an ambulance with that phone. And we educated them in syndromic approach. This talk volume about task shifting. As we didn't have enough professionals, we have doctors who have been educated to do to provide services that are normally in the hand of specialists in your country. We have nurses that do services that belong to doctors, like prescription of antibiotic, diagnostic of many things. Even community health workers do tasks of nurses and even of doctors, like prescription of antibiotic. So task shifting is very important, and it allows us to have services centered to the people in a holistic manner and find the people where they live. For the principle of equity, we have gender equity, so we do the best for all the women to have access to the service in the same way that the men have. Normally, due to economic different balance of power, it's not always the same. It was not the same before. Now, with the community health workers, 2 are women, it has changed. And also, for other services, we have what we call gender budgeting. In our budget, we identify all what we do for women, all what we do specifically for men. And we are sure that there is a balance. This helps in equity. This also helps in for children to have access. Now, the financial barrier for universal access. We have created what we call the mutuelle de santé, the community health insurance that belongs to the people. There is the 25%, the most poor, doesn't pay. The government pay for them. The others pay according revenue, and everybody have the same care. We have also health insurance for civil servants. Now, for efficiency, it's education for better use of each and every dollar we have, but also fighting, because we don't have much, we cannot allow to lose what we have, fighting to the last extent any type of corruption. Now, when we have the principle where we base our action, we need infrastructure, and this also is based on equity, to assure that each Rwandan have the same access, same opportunity to care. We are sure that in each village there is community health workers. In each sector, we have a health center. In each district, a district hospital is the first place we find a doctor. And each big city, we have a referral or a teaching hospitals where we found specialists. When we have infrastructure, we need people to provide the care. And this is what all this meeting is about, universal health care and health professionals. We didn't have enough. So we did what we call task shifting. I have explained that. But we did also a project called Human Resource for Health. For this project, we have a partnership with 20 high learning institutions in the US, and they send us 100 teachers every year, some for academic lectures or courses, some for mentoring, and others professional to help us in learning better management of hospitals, of high learning institutions, etc. And with this program that will run during 7 years, we will have produced better teachers in Rwanda, because they teach our teacher to teach while they teach and will produce 500 specialists. So infrastructure, health professionals, drugs, it's very important. Assure that we have a procurement system that brings the drugs in an equitable manner in all parts of the country, and reinforce the education system so that we have the health professionals that we need. But we need to keep them. So we do a contract with them that they have to work for us 3 years if they are doctors, 5 years if they are a specialist. But after that, I ask countries like you not to come and stall them because you have better opportunities for salaries, etc. Because it has cost us so much to educate them on the tax of our people and also on money we mobilize, that at least if you take them, you stole them, reimburse us so that we can educate another one. But with some penalties, because we are losing some years without service during the time we educate them. So another principle, universal access, you get it with all this, but you need to target the most vulnerable. Because if you reach the most vulnerable, that means you'll reach also other peoples. Because the poorest woman in a village, if she have access to care, that means everybody in the country can have access to care. So this is that we have to have in mind. And for the skeptical that believe that we cannot do all this because we are poor, we have proved them wrong. And I invite all of you to come and see that, because we need to fight that skepticism, because your health should not be determined by the place you are born. This is social justice. Thank you.